And there we go. So, good afternoon, everyone. My name is Mark Driscoll. I am the program manager for the Preventive Health Program with the Ohio AAP. And we have a very great presentation for you today. I just have a couple of notes from me, and then I will kick it off to our presenters. First off, I will be sending information about how to apply for CME and MOC Part 2 probably tomorrow. We're having some troubles with the website, so I want to make sure that it's working before I send that information to you. So expect that tomorrow or early next week, and then you'll be able to apply for CME and MOC Part 2. And then if we can go to the next slide. We just have our CME disclosure here. So any sort of financial relationships that were attested to us at the Ohio AAP have been mitigated, so they should not influence any of the presentation today. And then other than that, that's all I have. If you have any questions, feel free to pop them in the chat and I will ask throughout. Otherwise, I will kick it off to Dr. Williford and Dr. Crosby. Thank you.
All right. Good afternoon, everyone. Thanks for joining us today. Dr. Williford, so I'm going to start with the slides. Do you want to go ahead and introduce yourself first, and then I can introduce myself and go right into the slides?
Of course.
Okay.
So I am Desiree Wilford. I'm an assistant professor at Cincinnati Children's Hospital Medical Center and the University of Cincinnati College of Medicine. I am entering my third year of faculty, so I'm in my early career stage, but I'm not new to the Ohio area. Did my residency and fellowship here and have worked really closely with Dr. Crosby on some self-management work that we will talk about today. So I'll pass it to Dr. Crosby.
All right. Hello, everyone. My name is Lori Crosby. I am a professor at Cincinnati Children's and the University of Cincinnati College of Medicine. I have been practicing at Children's Hospital a really long time, like quarter of a century type time. And I can't believe that it's gone by so fast. But one of my favorite things to talk about is self-management and adherence. So really excited to talk with you all today about that. I'm going to ask Dr. Williford to move forward to our learning objectives that we're going to cover in this first of a three-part series. So today we're going to talk about, we're going to define adherence and self-management for you. We're going to talk about a pediatric self-management model that we have found extremely useful in trying to conceptualize adherence, assess it, and treat it. We're going to talk about some of the prevalence of adherence, what really is the challenge of adherence, what are some of the implications, both positive and negative, and then really spend some time looking at some of the psychosocial factors and drivers that affect both adherence and self-management. And finally, we'll end with a little bit of clinical discussion and hopefully have some questions from you. We'd love to hear some of your adherence challenges and see if we can be helpful with those, and then kind of give a preview for what comes next in the series. So next slide. So we're going to start with these definitions of adherence and self-management. So adherence is really the degree to which, right, a person's behavior coincides with medical or health advice, right? So you got the instructions from your doctor on your medicine or your treatments. How much do you follow that? 80%, 90%, 100%. And we'll talk about this as we go along, but I hope you're already thinking it depends. I hope you're already thinking that because that's great. That's where you need to be in the adherence discussions. Self-management is a broader it's a broader concept. And this is really to do with health behaviors and related processes. And so think about being prescribed a medication. You have to get from that prescription all the way to getting it, if it's a pill, in your mouth. And that is a process that might involve going to the pharmacy or having prescriptions mailed to you, involves taking it out of the bottle, maybe getting water or something to take it with, all these different pieces. And so it's sort of a process. And then the health behaviors could be anything from drinking water, lifestyle habits, to getting your labs or other things. So there's this combination of health behaviors and related processes. And adherence is just one piece of self-management. So if we go to the next slide, oh wait, don't go yet. I wanted to do a guess. how many people, I wanted to do two things. One is how many people have ever gotten a membership to something and didn't do exactly what that membership is. So for example, maybe you joined a gym and you paid a monthly fee, but you didn't go every month. Maybe you joined something else. If people could just put their reactions up. Okay, I'm with you. I'm with you, Pamela. I'm with you, Chris. Yeah. So many of us, we do these things, we join them, we do whatever, we have the best intention, but we can't always get our behavior to go there, right? And so what we know is that the prevalence of non-adherence is vast. All of us are non-adherent in some way to something. So I just wanted to say that. And so if we're talking about adherence, prevalence of adherence in children with chronic conditions, what we know is, well, what do you guys guess? Maybe we could put this in the chat. What percentage do you think children are like 70% non-adherent, 80%, 10%, because they have their system, it's also known as the parents or family. What do you think the non-adherence rate is for children with chronic conditions? You guys can just throw it in the chat if you have any guesses. You may have already seen the slides, so you may have already given it away. Okay, thank you, Tanya, Chris, Pamela, Tika. Yes, yes, these are great numbers. And I would suggest that you see all of these numbers in your practice because what we know is that people are non-adherent differently, that it depends comes up, and we'll talk more about that. So in general, if we had to average these numbers out, we'd say it's about 50%. So if we go to the next slide, Dr. Williford. 50% of children with chronic conditions don't consistently meet guidelines, and 60 to 95%, 65% to 90, especially of adolescents, are inconsistent. And I know you have some ideas about why. I love the adolescents. Those are like my favorite peeps, but they have a little complexity to them. And so adherence becomes much more complicated during that time period. And so that's why you can see that rise in adherence and non-adherence rates. And what we know is that adherence starts out good. We all start out strong. I joined that membership. I'm going to go to that gym 3 times a week. And then usually about 6 months in, that's when things can start to decline. So just to think about that context. And today we're really going to be focusing on the context and remembering that the context matters. And that's why the adherence it depends. So we'll talk more about context as we go along. So part of the reason it depends is that adherence is this dynamic process, right? And so adherence behaviors vary wisely. And sometimes we say in our mind, I'm going to do this part, but I'm not going to do this other part, right? So I'm going to go get my labs drawn, but I'm not going to do the dietary changes that they asked me to do. Or I'm going to do this part and not that part. And so it's this dynamic process. And then there might be times where we might be more adherent because of our developmental stage, family dynamics, things like that. Maybe the complexity of the regimen is easier. Taking a pill might be easier than going to get labs and taking the pill and having your blood, having some procedure and all of that. And then sometimes we don't really understand why we're being asked to do what we're doing. Or we might say that we understand in a soft way, meaning like we'll say it, but we really don't understand. And so it doesn't really translate to our behavior. And then it's really, again, context dependent and flexible. And it can also be affected. The good news is it can be affected by our daily routines, by our stress, and by some of our activity level. And so if we can start to think about how can we impact those things like that daily routine, how can we make it a less stressful experience, and how can we make sure people have access to what they need to have access to, that's where we can start to intervene on adherence because it is this really complex problem. So I want you to feel like it's unsurmountable. Dr. Crosby, you've talked to us and now it's insurmountable. I want you to feel like that. Okay, so suboptimal adherence is common across all populations. And here you can see some examples of the percent of non-adherence across a number of chronic conditions in childhood, like asthma, diabetes, GI, rheumatoid arthritis, transplants, cancer, and HIV. So even some of the heavy hitters like transplant and cancer, you can see that there is significant non-adherence rates. And as you can imagine, those non-adherence rates can have a significant impact. And so what we know about the trajectory, kind of how this works, is that again, right after diagnosis, we know that it's typically highest. And then motivation and support are also highest at that time. And then there's usually a gradual decline. And some of that comes from competing demands. A regimen might increase in complexity. Some of it might become, the adherence becomes kind of boring, like it's routine, right? And it's like we kind of get bored with it. And then also with children, there may be increased autonomy that might also influence that trajectory. And again, we know that adolescence is that high risk period. And so that's something for us to kind of watch out for and plan for as we're thinking about adherence with our patients. I just want to say, as we're thinking about the significant consequences of suboptimal adherence, again, I want you to also be thinking about the opportunity for support. You can see the need for creativity and the need for intentionality. So be thinking about those as we explore this. And so what we know is the consequences of suboptimal adherence are not good, right? And so not only is there just reduced treatment efficacy, right? So if it doesn't get so much doesn't get in your body, it doesn't work. But also if we are inconsistent with our medication, then sometimes we might have medication interactions or other things happening, right? And medicine, we might think it's not working when really it's we didn't take it. And so medicine can be escalated, right? When it really didn't need to be. There's also drug resistance. We can develop resistance because we're on and off. And then there's higher morbidity, mortality, and other severe health consequences. And the literature has shown this over and over again in different diseases that when you have poor adherence, the outcomes are also negative. So what about the psychosocial parts of adherence? So what we know is that people who are not adherent to their medication typically have lower health related quality of life. And so there is a connection between those two. We also know that adherence and family stress kind of go, or non-adherence and family stress kind of go hand in hand. And so we see those two things correlated in studies or connected in studies. We know that sometimes there's a worsening of mental health symptoms when adherence is low, and also that trust, communication barriers, and that relationship with that team can really be impacted by non-adherence, right? Because when the adolescent, I'm just gonna say adolescent, when the adolescent comes to clinic, we're like, oh yeah, this adolescent is coming. They are not taking their medicine. They're not doing what they need to do. And so we may have difficulty trusting them to start a new treatment plan. We may not communicate with them in a way that is optimal in terms of supporting and motivating them because we have been sort of affected by their non-adherence in the past. So one thing to think about is that I hope you're with me so far that adherence definitely needs to be assessed, that it should be monitored throughout treatment. Remember that trajectory, and that again, that context matters. And so it is so important that we figure out a way to put all this information together in a way that helps us to be able to move forward in that assessment and make the most effective interventions. And so one way to do that is to use a model. And that's what Dr. Williford is going to talk about next, this model of the pediatric self-management. We call it the pediatric self-management model, but it's really a model that helps us kind of put this all together and move forward. So I'm going to turn over to Dr. Williford now to talk about this.
Perfect. Thank you, Dr. Crosby. So, as Dr. Hasby mentioned, I'll be taking us a little bit through a specific model of pediatric self-management. My goal is to try to not get too much into the weeds and share lots of practical examples as we go along. But I did want to just kind of bring it to the science a little bit of all of this complexity that Dr. Crosby just introduced us to. So on this very busy slide, you will see the pediatric self-management model. And basically, I'm going to be working from left to right across this. So if you look at the circle with the four colors, starting right in the center of that is our self-management behavior. So that and the model itself is talking about the interactions that Dr. Crosby introduced us to. So in the middle of the figure is, again, the behaviors. And then those behaviors operate within individual, family, community, and healthcare system domains. Within each of those are affected by both non-modifiable factors. So think of things like a person's age, their cognitive status, things that we can't change, but as well as modifiable influences and things that we can target. So thinking about things like someone's treatment knowledge or the level of conflict that they have in their family and their kind of mood and overall understanding of their condition. When we think about moving over to adherence, where this falls is that really it's thinking about, again, the recommendations that we give and how this complex intersecting factors influence those specific behaviors that a person may or may not engage in for a variety of reasons. So adherence and self-management are different but interrelated constructs because suboptimal adherence can be the result of suboptimal self-management and all of these things going awry. But also self-management itself, those patterns, those interactions, those factors can also directly influence the outcome. So it's not always just through adherence that we see impacts on health behaviors. So to make this a little bit easier, I decided to kind of break this down domain by domain and just give some specific examples. So again, as I mentioned, when we're talking about the individual, we're thinking about the patient that walks into the room with us, that we're just talking to them, asking them about their disease regimen, what they know, what they don't know, how they're engaging in their health behaviors on a day-to-day basis. And we know when we're walking into the room, the first thing that we see is a child, right? We cannot change the fact that they're a child. We cannot change their developmental level, although we wish sometimes that we could, because you might be faced with a really argumentative teen or a teen that might say nothing to you in the room or have their hand crossed before you even walk into the room with them. But what we can do is ask questions to understand how much they know about their health. And as providers, you probably are aware of this. That really varies. Sometimes they know a lot. Sometimes they know a little. Sometimes you're not even really sure based on how they're talking to you, how much that they know about it. But they also exist in a world of being a teen that has to exist in their day-to-day life every day. So they might have their own internalizing and externalizing behavior. They might have their own executive functioning concerns, and all of those things affect their self-management and the barriers that they might experience. So when we think about these domains, we might think about barriers such as the suboptimal knowledge, like I already talked about, but even things like forgetting. If they're fully responsible for their regimen and they're forgetting on a day-to-day basis, we also know this could be for a lot of factors, including the fact that our teens are having to wake up really early in the morning for school. They might not like to do that. And if they're taking their medicine every single day in the morning, they might forget because of those competing demands or because their brain's just not really aligned with the time that they're supposed to be waking up to be getting ready for school and doing all of those things. So this is just another, you'll see this table a lot as we go through, but just some more examples to kind of put this into action. So as I mentioned, one of the non-modifiable factors would be someone's cognitive functioning or their IQ level, but something that is modifiable is their knowledge of their disease. And so we can think about how we tailor, how we talk to them about their disease regimen so that they can come back and tell us specifically what they know, what they don't know. Other processes that interact with this are health beliefs and values. So while we would really love a teen to come into the room and say, I take care of myself because in the long term, I want to live a healthy, long life. That's not always what our teens say to us and how they experience their life. They're often very focused in the moment, in the now. And sometimes we have to think about how to activate those specific values when we're talking about adherence. So thinking like, they might, not really care about their disease self-management. They might feel like it'll be fine. I'll be fine in the long term. But what they do care about is being a star player on their soccer team. And if we can align their disease self-management with, hey, it'll make you miss less practices. It'll make you not have to miss those big games because you're in the hospital or doing things. We can activate some of those values to help support behaviors, as well as figure out what's developmentally appropriate for how much responsibility they're taking and how to activate those values to kind of encourage more participation among other members, which we'll talk about when we get to the family domain. So moving to that family domain, again, often when we're interacting with our patients that come in, they're often not coming to their appointments alone. Who might be in the room might vary widely. So I want us to think widely about family here. It's not always just caregivers. Sometimes it might be a grandparent. It might be an aunt, an uncle. Sometimes it's a friend that comes into their appointment. But who their social context is that's immediately right there, present, engaging them day to day is what we're talking about here. So there are a number of non-modifiable factors that we can't change. We can't change who's in the room with them right now. We can't change caregiver relationship status, how many people live in their home. Those are factors that are outside of our control as individual practitioners, or the fact that that they may or may not have support at certain times during the day, like things of work schedules. But what we can influence are the dynamics that these individuals have, whether there's conflict that's happening between the patient and their family member around self-management behaviors or their disease. We also know that similarly to individuals, caregivers and other family members have their own values and their health beliefs, which then can influence the youth that are in the home as well, especially when those values are not aligned. And so again, thinking about where we can have impact are things like communication among the family, and also whether there's a mismatch between the roles and responsibilities, what the expectations are of the caregivers on the youth, and whether that meets their developmental level. I think this example is mostly of what I talked about and shared. So I'll briefly talk about this. But again, thinking about some of those contextual factors, one that I did not talk about yet, are thinking about anxiety and depression and how this can be affecting both the individual, but also our caregivers. So our caregivers might have their own mental health symptoms, their own experiences, their own burnout related to treating and caring for diseases, and how that has trickle down effects for the teen or youth and their individual behaviors and the level of collaboration that is happening in the family. When we move to the healthcare system, we also have to think about, again, that we can't change a patient's insurance status when they walk in the room. We might be able to do things such as, if they don't have insurance, help them or provide them resources with getting insurance, but we can't change right in that moment what they have access to in terms of those larger systemic factors. But what we can do, as I mentioned, is make them aware of things that will help support their self-management. So helping them sign up for my chart so they remember their appointments, helping them access and interact with the healthcare system, providing transportation so that they can help get to and from their appointments. Those are all things that we have control of within our healthcare teams. But again, our values as a healthcare system is an important process to pay attention to because they don't always align with our individuals and our families. Just like I mentioned, we want everybody to care because we see X, Y, and Z might happen, or you'll be at X, Y, and Z increased risk if you don't do this behavior. That's not always how our patients and families are thinking about the circumstances. So we can think about how we communicate and interact with our patients so that we're not just doing fear tactics, but also really meeting them where they are and involving them in shared decision making. And so, as I mentioned, this example is pretty similar, but thinking about really where we have influence is the relationship that we have with our patients, but also the way that we train our future colleagues or our current colleagues that we're working with on how to engage in shared decision making, how to be aware of these different factors like we're talking about today, and have conversations with our patients and families about it, and then continue to spread that knowledge and grow in it over time so that we're continuing to improve our education, our awareness, and meeting families where they are in terms of their adherence and self-management. And then finally, in the community domain, we'd like to think about that larger umbrella of life. So we talk specifically about the caregivers, but they exist in larger families, in larger support systems, in larger, teams, in schools, things that we frequently interact with, especially when thinking about pediatric patients. I know often I talk about school. That is one of the biggest things that I talk about with patients and families, because there can be very different amounts of knowledge about a disease in school, the access to resources such as school-based nurses, or the level of attention that a teacher has based on the class size to how much individual one-on-one attention they can give to an individual with chronic health needs. And so we have to think about that interacting process and how that impacts behaviors that our youth are engaging in when care is involved in the school setting, which often it is because they're in school for a big portion of their day. Another important aspect in this is thinking about stigma. Sometimes people live with visible and non-visible diseases, and that can really come with its own barriers, especially during developmental periods where social relationships with peers are growing in importance over time. This is a very big thing with our teens, especially, is that they don't want to feel different. They're trying to fit in. They're trying to feel connected to other people. And sometimes they're taking care of their health is one thing that makes them feel different and stand out when they're already trying to fit in and to experience world as a teen without having extra eyes or extra attention on them. We're already starting to notice things like increasing feelings of lowered confidence and just feeling pressure to be like everybody else, or to nitpick all of the details of how we look and how we interact. And so sometimes this can be another barrier for our teens. So again, I mentioned this already, but really thinking about the ways that the different groups that we interact with contribute to all those feelings around acceptability. We do at Children's a lot of training with teachers and with schools. I work in a diabetes center, and we have school-based health clinics for this very reason. We have lots of kids that do not have availability of support, and sometimes teachers aren't meeting to victimize, but when they have 18 to 30 kids that they're interacting with, sometimes it's just easier to tell that kid to go to a different place because they're wanting to give them care, but now they've been pulled out of the educational environment and the learning, and there are trickle-down effects of those things. So very briefly, I know we've already been talking about all these different factors, but I also want to give context to the fact that there are larger social and structural factors that influence adherence and self-management. We know that there are differences in racial and ethnic groups in terms of these factors, but it's often not a biological factor. These are social constructs. And so we know that they're often proxies for other experiences of marginalization or feeling different, and trust within the healthcare system because of experiences over time, or feeling not heard or not listened to. This can place families that experience marginalization for a number of reasons. We're seeing this a lot with acculturation and language status right now as well, and individuals who have varied socioeconomic statuses. And there might be greater barriers just to these community and healthcare system factors. So it's really important for us to not just think about when we see a patient, their race, their ethnicity, these specific factors, but also how their intersecting identities might affect the behaviors that they engage in, especially if they're doing things like a person that already has financial barriers. They might be traveling long distances to clinic to receive care. They might live in a rural or less resource community. And so we might have to tailor the recommendations or the treatment plans to meet the needs of these larger contexts. So on the next couple of slides, I know these look busy. Don't worry, you don't have to read them all, but I just wanted to give context that a few of the speakers you'll hear from, including Dr. Crosby and myself, have really been thinking very hard about how to explicitly call out these factors within the pediatric self-management model. And so we're very pleased to report that we just had a publication accepted to the Journal of Pediatric Psychology that will be coming out soon, and we're happy to share that when it's fully published. But this table that I'm sharing with you is directly pulled from that publication that really just points out the unique contributions that are italicized across the table of both moving beyond just demographic factors, but really contextualizing social drivers' health across individual, family, community, and healthcare system levels. So in this, you'll see, again, some examples of those demographic factors that we've expanded and really putting them in the context of experiences that relate to trust, interactions with others, and communication. And also particularly ACEs, we've called out as well. In terms of geographic and socioeconomic and healthcare factors, we're really drawing a lot more attention to the neighborhood and the built environment. So thinking about how economic stability, poverty, food security, housing stability affects the availability of resources and a family's ability to meet those requirements of their condition. So thinking about things like someone's food environment, if there's a condition that has specific dietary recommendations, do they have access to those foods? They have access to a grocery store or to areas where they can walk safely or play in order to meet the exercise and dietary recommendations that we're providing with families with. And then in terms of those, moving down to some of those other factors, Dr. Kai's mentioned more psychosocially, thinking about how social drivers' health affect things such as disease knowledge, health beliefs, and psychosocial functioning, and really contextualizing not only the adverse impacts of social drivers of health, but where we have sources of resilience. We often talk about the villages that our patients and families have, who they lean on, what resources they have access to. So really drawing attention to those aspects of social support, relationships, and access to resources that support their adjustment and their self-management behaviors, as well as positive interactions between patients, families, and medical teams. So for our last little bit of the talk today, we wanted to kind of go through a case example with you all, hopefully make this a little bit more interactive, and Dr. Crosby and I will go kind of back and forth. I'll introduce the case for us, and then we'll kind of ask some follow-up questions, have some discussion around how the model and some of the factors that we've talked about already might apply to this specific case. So I present to you Erica. Erica is a 15-year-old Black female that's on public insurance. She lives with her mother, father, and 3 younger siblings in a rural town. She has been diagnosed with severe persistent asthma for the last 6 years, and historically has a history of optimal adherence. She's bright, she's tells you about her care, knows kind of what to do in the moment, and you've been really impressed with her over the years. However, you just noticed that you haven't seen her in more than 9 months. And when you look at your prescription refill data, there's nothing popping up into the chart. It might be an error, but it might not. And we also have noticed that when you look and talk with your social worker, there's been a recent history of several late call no-shows to follow-up visits scheduled with you. So we want to talk a little bit about what your team's next steps might be in this particular case. You can throw things in the chat. I can't see the chat, but Lori, maybe you can help me.
I can see the chat. Can you go back, Desiree, so people can look at the
Yes. Oh,
case
of
while
course.
yeah. Okay, we have trying to contact her parent. It's great. Yeah, I think trying to contact her parent is a great one, because you're trying to understand that context, right? Something is different, something is happening, and you know it might not just be with her, that it might be a larger impact, especially with the prescription refill data. You're thinking it might be larger than just her. So I like this. I like these ideas. Another is ask open-ended questions about her health, which is great, so that when she does come and you notice that there's something going on, asking those more open curiosity, like open-ended type questions to kind of find out what's happening. And then the last one so far is send a letter, which is also great because maybe they're not even coming to the appointment for you to ask the open-ended questions. So reaching out by letter to say, we haven't seen you in a while. We miss you. We can't wait to see you for your next appointment. Or my chart message can really be helpful. These are great ideas.
Yes, thank you so much for sharing. Yes, so I asked an open-ended question, but you guys definitely shared some of the important factors. So some things that I'm thinking about as we talk along is just thinking about the fact that it's been that over 9 months, right? This is a recent change for Erica, something different. So I really appreciate that people's ideas are to first reach out and to think about that there might be some growing challenges, and this might be an early sign of some challenges that she may be experiencing. What if I told you and added to this a little bit? What if I told you that Erica's been calling herself to inform the team of the cancellation? So she's the one that's calling last minute. What considerations might you have if you have that additional information?
So one thing in the chat is to, if your letter doesn't work, for example, to consider a home visit. Another idea is to check with the school personnel.
I love these ideas, thinking more of that broader context, thinking where you might be able to reach them. I love that. Absolutely. So that comment definitely gets me really thinking about those things, and really also thinking about that there might be some unique dynamics in the family or with different social drivers of health that might be forcing or leading to our teen having to take more responsibility in their treatment plan. I do think it is a good sign that they're calling in the first place, because I can't think about many teens that would pick up the phone and call to cancel their appointments on their own. And so this might also be an indication of some strengths that our teen has in addition to the challenges that they're navigating. So I always try to think about both those pros and challenges at the same time. So it might be an opportunity for us to work with the family, their network, their school to problem solve, increase the likelihood of attendance, and also reduce some burden on Erica and her family. This is great. Thank you.
Yeah,
So you can
one
see
just really quick,
oh
one
yeah,
other thing in the
yes,
chat is thinking about why did she cancel? Really
yeah,
considering like what might be some of the reasons that she may have canceled.
I
And
love that.
understanding from the person who talked to the phone, what did she say? Like, why did she say she
Exactly.
was canceling? Yeah. So just another idea in the
Absolutely.
chat. Yeah.
Thank you. These are great. I really appreciate the participation of the chat. So a lot of these options. So we you guys have been great, have been talking with us. But I did put it kind of in multiple choice form here. So I just have a quick in the chat. You can kind of vote for some answers of what the next steps are. I kind of feel like you guys are going to say are going to definitely say the right ones. But any thoughts on what next steps might be?
And there's another one also about thinking about transportation. So thinking about
Oh,
those community
absolutely.
level, maybe family level factors. And there's a lot of D's in the
Yep.
chat coming in for
I love that.
responses.
It's awesome. Perfect. And you are right, right? It's a little bit of a trick question because there's actually a couple correct answers on this slide. But yes, you all already mentioned that contacting the family is going to be really important, whether that's via phone or through those other methods to think about how we can get them back to clinic, that we are really excited to talk to them. But you are definitely right. D is also correct to just figure out what those barriers are. Think about if there's any solutions you as a team can help get them there, and to help have a conversation with them, and what resources you might have access to do. So some teams might have a social worker, a health worker. Sometimes you're calling yourself as a provider. We've had providers and teams tell us that as well, to help get them there, figure out what you have resources to do to be able to support them.
The other thing I wanted to say about the second one is if you're thinking about when you're talking with mom and you're normalizing that, and there are barriers to adherence, right? So thinking about that, we think about that for our patients sometimes, like, oh, we know that, but we talked about 50%, right, of kids and 65 to 90% of adolescents are non-adherent with treatment. So it's really normal. We talked about that trajectory of adherence, right? Like it changes over time and it can decline over time. And so really normalizing that can make a huge difference when you're talking to someone. So instead of saying, what's going on? Why are you here? But saying, we know that adolescents have a lot going on, and we know that it's very difficult for them to, stick with their treatments. How are things going for you? That's a lot different than just saying, what's going on? Why haven't you been at your appointments? So you see the difference versus the normalization. So really asking that in that context can make a huge difference.
Absolutely, absolutely. And I think that also gets to a point of why A and C might be less preferred options, because when we're thinking about, it might be really easy for us to say, oh, we'll just put them in the next opening that we have. But if we're not really understanding what the barriers are, just changing their appointment might set them up for even more no-shows and even more things that are documented in their chart, because we're not really understanding or getting to the root of what the challenge is for them getting there in the first place. And then, unfortunately, I have seen C happen as well too. If like you have to come in, or else we're not giving you your medication. Which, while I understand the intent behind that, if there are barriers that are systemic to getting there in the first place, this might actually further worsen the problem that you're trying to address in the first place. Because now they're being penalized, their health is being penalized, for barriers that may or may not be out of their control, or things that we can help them problem solve and work around.
Another barrier, Desiree, that's in the chat has to do with trauma. And
Yep.
so the individual wrote, if anyone has ever seen their child or anyone struggle to breathe, it's terrifying, right? And so trauma
Absolutely.
can really, thank you for bringing that up, because trauma can
Thank you so
really
much.
impact adherence. And so that is something that to consider as you're going through and thinking about individual factors and family factors and
Yeah,
community factors and societal factors, really thinking about where trauma may live and how that may be influencing the adherence behaviors that you're seeing. And
absolutely.
that communication and trust with healthcare providers, all of those things.
Absolutely. And even down to, attending medical visits. We have had, after a patient is hospitalized, the very first thing that we often see is like, you got to get in with your physician after and follow up. But if they've had a really traumatic experience in the hospital, the last place they might want to actually be is the healthcare medical center, especially when in some of our instances where they're care is being received in the same hospital where they just went through trauma. And so there can be barriers to even attending those visits related to just reliving the trauma and the stress of having just navigated something really hard and difficult. So yes, thank you so much for bringing that up. That's important. Any other comments, Lori, before I move to second part?
Now, right
Okay,
now.
perfect. All right. So I'll give some extra context. So next part of Erica. So just like you all mentioned, this team has a social worker and they contact the family via phone, expressing concern around the non-attendance, but doing it normalizing the context of the family's busy life. Asking those questions like Dr. Kazi mentioned, just open-ended and just saying, how can we help? How can we get you here? And the mother goes onto a laundry list. I'm sure anyone might have had experience being on the phone of all of the things that they are stressed about right now. They have so many unmet needs. The Erica's younger brother has significant developmental and behavioral needs that they are also trying to navigate as a family. They lost their second car, and so they're relying as a family on one car to get everywhere with conflicting work schedules and very demanding work schedules. And so while they prioritize their health, it's just been really hard to get to these appointments. And they've really had to rely on Erica to navigate and cancel these appointments at the last minute. We do get the social worker normalizes, helps arrange transportation, helps them get signed up for My Chart so the family is aware of all of these visits, and they get an appointment scheduled within 2 weeks. So I want us to kind of take a pause here and just think about with this extra information, what we know and how we can prepare and best set up for this visit that they're about to have in 2 weeks.
So I think you want to put ideas, you want people to put ideas about what they might discuss or what they might want to do when they come in.
Yep, absolutely. And this is building off some of the great comments you said, because you said you wanted to know kind of what the reasons are, what they're saying on the phone. So this is what you're being presented with.
Okay, we have one response in the chat right now that says, are there other options for Erica as telehealth or visiting nurse services possibilities for her during this time period when, transportation and other things are a challenge?
Great. I love that. Yeah, just trying to
Mhm.
think of where your roles are in the healthcare system, what you have control over, and what you can do to reduce barriers for the family. I love that.
There's another one that says, I love this. Is there a way to schedule appointments for the sibling and Erica at the same time? So it's one
Love that.
trip.
I love that. That's great. Because as you can imagine, they're navigating multiple parts of the healthcare system at the same time. So I love that. Great, great points.
I think one of the things that we sometimes forget to do is sometimes it's really hard to ask for and accept help. And so I think one of the things that we sort of forget to do sometimes is mention that to families. We are so glad that you were able to take advantage of those supports, related to transportation and appointment reminders. Um, Thank you for being willing and being open to doing those things, right? I think sometimes we just forget to comment on that common acceptance of help because it is sometimes when you're managing a lot of things it's hard to ask for that help. And so when someone accepts it, we want to be gracious about that and thank them for that because it also reinforces possibly their ability to do that in the future as well. And then we have another comment. The social worker could assist the family with transportation and attend that visit as well for more support. That's a great idea to have that social worker involved in the visit so it feels more seamless. It's great.
Absolutely. Absolutely. I love these points. Yes. Thank you so much. I think, yes, I think those are the so important factors to consider. For sake of time, I'll run really quickly through the next part, and then I just want to make sure that we have time for questions and things here at the end. But to all of we'll say all of the things that you guys said were implemented, but somehow we actually got Erica to clinic, right? So that's a win for us. We got her to clinic, and her mother's with her. So we have had one big win already getting them then there. They're filling out their assessment. So we give them kind of the standard measures that they fill out in their clinic. And you find out from the medical assistant that Erica needs refills of all of her medication. So she only has one expired rescue inhaler at home. She has been going kind of without medicine for quite some time. And her screening results suggest some potential experiences of moderate depression and anxiety. Her asthma knowledge still remains through the roof. She's doing great with that. But again, we're seeing consistent reports of those financial and transportation barriers. And so just want a couple of thoughts in the chat, if you guys could, for us, of just thinking about some considerations, having this additional information of how we might move forward with this, especially knowing that the family is really apologetic. They're coming in with a lot of emotion and like worry about how the team is going to react to the fact that they haven't been here, because we often see families presenting this way, that they're worried about the impact that it's going to have on them having had this history of barriers.
I'm just going to ask more specifically also think about the depression and anxiety.
Yep.
What would you all want to do about that? What might be next steps related to that? So one thing in the chat is the part addressing the issue of making of them worrying that that the medical team is judging them and you know will not understand. It's like working with them to let them know that they're not judged, they're not being judged. So the social worker and the medical team letting the family know that they're not being judged, in fact, and we're delighted that they're here and we understand that that's a real strength for them. And we know that this is important to them. We understand it's a value for them. And so it's our job to help. And that there might be times where we can help more and times where we we don't need to help as much, and that's normal and that's okay. So yeah. So for the sake of time, Dr. Williford, do you want to give ideas about what we might do next about the depression? Oh, someone is saying a PHQ-9 assessment and then recommend treatment options for anxiety and depression. Great.
Absolutely. Absolutely. Yes. I really appreciate you asking that specific question. And I will say we're precursing a little bit to some of the talks that are coming followed after us. So Dr. Crosby and I had the lovely pleasure of getting to introduce you to these concepts, but you'll have the next in the series will be one on assessment and one on intervention more specifically. So you'll have some more recommendations. But I think that this is really common, right? Our families have a lot of pressure, a lot of weight on them, a lot of experiences. And so while we traditionally think about depression and anxiety as like symptoms that we assess or that we measure, they might be very intrinsically related to the self-management that we're feeling. If they're feeling all this pressure to be independent, to do things, and facing all these barriers, it might also affect their mood and their level of motivation, all of which can present as symptoms of depression and anxiety on a screener. And so these do not exist in a vacuum. They are all intertwined with one one another. And so thinking about how we tailor our treatment recommendations and the ways that we talk about this as not individual separate things and normalizing, like Dr. Crosby said, around dealing with this chronic illness is hard. Over time, it just feels like it keeps getting harder and harder. What's your experience with that? How do you feel on a like day-to-day basis? And then just saying, I noticed that you were really honest with us and told us how you were feeling on these screeners. What does that look like for you? What on a day-to-day, what do you think gets in the way? What makes it hard? Is it hard to navigate those symptoms? What are you doing right now to help take care of yourself? Who do you lean on? Who do you trust to figure out again what some of those sources of strength for are for them, but also the things that they're struggling with and navigating. And that might tailor whether or not you might do something such as a referral to a psychologist or to a resource that they have access to, whether that maybe is giving them more time with their friends or with other people that they know. Maybe they just feel alone and isolated. Maybe we can help them think through and problem solve opportunities to build connection and support with others. So really understanding what the causes of those symptoms are, what's contributing to them can help inform your next steps and your treatment recommendations.
Okay, we have a couple of comments in the chat.
Great.
Just normalizing that everyone has hardships and the team is there to help, not hurt. Continue to talk to the parent and the student, not at them. And I love that, talking with them instead of at them. And then making sure that the patient has many more refills before leaving the appointment, at least six more refills. Yeah. And I know we're down to like about 4 minutes. So if I don't know if we want to open it up to any questions at this point, any general questions on assess adherence. We're trying to kind of provide an overview, a context, and then as Dr. Williford said, our next colleagues will be focused on how do you actually assess adherence? What's the language? How do are there measures? What do you do with that? And then the last one will be on intervention.
And again, feel free to put any questions into the chat, or if you'd like to unmute, you can also unmute and ask a question.
I really appreciated your comments too, Desiree, about how the framework affects both through adherence and directly. I think that's a great concept to remember, that adherence is sort of a modifier, it sounds like.
Absolutely. I think that's a big part that we forget sometimes. It's like we are so focused on the individual behaviors or
Right.
what the treatment regimen is, but it really does exist within this larger context.
Well, feel free to put any questions, but I will kind of give my ending part here. I want to thank our speakers, Dr. Crosby and Dr. Williford, for a great presentation, and we're looking forward to the rest of the series as well. So hopefully we will see you all there. And then I want to give a big thank you also to our sponsor, the Department of Health, for allowing us to have this webinar today. If you have any questions about the presentation, feel free to send them to me, and I can send them on to our speakers. Yeah, just another big thank you, and hopefully we will see you next week for our next session.
Thank you so much for your engagement. I really do appreciate it. That's what we were hoping for, that we weren't just chatting at you for so long. So thank you so much.
Yeah, thanks for the
Thank you, guys.
opportunity to talk about these issues. Yes. All right.
Great.
Bye, everyone.